It is increasingly common to see the outcomes after surgery published for different procedures. The Vascular Society has led the publication of information on the outcomes of vascular procedures, such as AAA repair, and we expect the range of this information to be increased in the coming years. It is common for information on NHS hospitals or surgeons to be published in a table that gives the number of procedures performed and some measure of outcome, such as post-operative mortality. The temptation with such a table is to rank the providers. However, this would be misleading and it could cause people to draw the wrong conclusions. Figures for hospitals or surgeons will always differ from each other because of random variation, and this variation is not communicated in a table nor when figures are ranked. To show the effect of random variation, figures will also be published in a funnel plot. Here is one example of a funnel plot. It is a funnel plot of post-operative mortality after the elective repair of an abdominal aortic aneurysm for vascular surgeons. Each dot is a surgeon and the horizontal line is the national average of 2.2%. The dots higher up show surgeons with higher mortality rates. The dots further to the right show the surgeons who perform more operations. As you can see, the surgeons who do more operations are more tightly clustered around the national average. This is because there is less random variation in bigger samples. This is also shown by these two funnel-shaped dotted lines. These lines define the region within which we would expect surgeons to fall if their outcomes only differed from the national rate because of random variation. If someone fell outside the outer limits, there could be a systematic reason for the higher or lower rate, and they will be flagged as an outlier for further investigation. In this example, no surgeon fell outside the outer limits and no one was flagged as an outlier. Presenting these figures in this way is only one element of publishing outcomes. It is important that the data are accurate, and so considerable time is spent on reviewing the data. In addition, we would need to ensure the outcomes are comparable. It would be unfair to compare the outcomes of a surgeon who operates on more frail, elderly patients with someone who operates mostly on younger, fitter patients. So we use data on patient characteristics to calculate risk-adjusted figures. This risk adjustment produces figures that indicate what we would expect to have happened if all surgeons operated on a similar group of patients.